不太确定这个。
我还记得这个。
怎么亮？So the first specimen is coming from a 63-year-old female who presented at our hospital with neurological symptoms and signs. So through image study, she identified the doctor identified some mass lesion in the lung and was suspected to have metastasis to the leptomeninges. So this is her CSF specimen. So she do not have any biopsy proven malignancy yet in our hospital. This is her first specimen, which is only the CSF specimen. And apparently, I think the clinician don't want to do a biopsy because maybe there are some clinical conditions. So the clinician already ordered the liquid biopsy for NGS testing without any pathologic proof to have lung cancer. So this is her very first specimen in our hospital. So in this specimen, because we know in CSF specimen, usually we won't see any cells. So here we can see some like smaller mononucleated cells, maybe some inflammatory cells. But here we can definitely see some larger atypical single cells with relatively irregular nuclear membrane and eccentric nucleus. So this is consistent with a metastatic poorly differentiated adenocarcinoma. And the most common origin is coming from the lung. Plus, the patient do have the clinical impression of lung mass. Because apparently it seems that the patient was not going to receive any biopsy, so these becoming the crucial specimen that we want to identify the origin of the cancer cell. So for the CSF specimen, we usually do two cytospin, one for alcohol fixed pap smear, the other is air dry. So we just see the air dry smear, and this is the alcohol fixed smear that we remove the cover slides, and we send the slides for TTF1 staining. So you can see the tumor cells are positive for TTF1 in the nucleus. So this is a strong evidence that this is coming from the lung origin. And as you can see, we do have a lot of tumor cells in these specimens. So indeed, the patient has metastatic adenocarcinoma, and we prove that it is coming from the lung, just with 5 millimeter CSF specimen. So the second case is coming from an 80-year-old female who had a past history of gastric cancer. This is her ascites specimen. So gastric cancer is relatively common in East Asia. And when we see advanced stage gastric cancer, most of the time it is a poorly differentiated adenocarcinoma with signaling ring cell morphology. So we know that the patient do have history of gastric cancer. So when we screen this type of specimen, you should usually be more careful, because these specimens on low power can look totally benign, because we rarely see any aggregates of epithelial cells. But when you go to higher power, you can appreciate that most of the cells show eccentric nucleus and the size is enlarged. And also, it is not uncommon that we can see prominent nuclear light here and there. So this is consistent with dissemination of a poorly differentiated adenocarcinoma of the gastric primary. So most of the cells are indeed tumor cells. So the next specimen is also, oh, this is from the same patient. So the next specimen is a 70-year-old female. This is her pleura effusion fluid. She presented at our emergency department. So pleura effusion. On low power, we can already appreciate there are some tight aggregates of cells. So we see second population. So this is likely metastatic carcinoma. So when we go to higher power, unlike the most common lung adenocarcinoma, these tumor cells does show intracytoplasmic mucin. In our hospital, when we perform the pap smear, these mucin oftentimes have these oranginophilic like color, suggests it's like a intestinal type of the mucin. So here we can see more clearly that we do have an eccentric nucleus, abundant cytoplasm with oranginophilic mucin pushing the nucleus to the periphery of the cells. So this is uncommon for lung cancer, and this is likely coming from the GI tract, particularly pancreatobiliary tract. So just by the cytomorphology, we suspect the patient have the pancreatobiliary adenocarcinoma, and with metastases across the diaphragm to the pleura effusion. So the patient do suspect to have a pancreatic cancer, and so this is likely coming from the pancreatic cancer and not the lung primary adenocarcinoma, just based on the morphological feature. So the next specimen is a washing cytology specimen. The patient received colorectal cancer operation, and this is the specimen during the operation. So this is a peritoneum washing specimen. So for the washing specimen, the interpretation is different from the effusion specimen, because for the washing specimen, this is very common that we will see large fragment of the cells, because the cells are like washed, so there is a mechanical force to move the lining cell, mostly mesothelial cells, to the specimen. So it is not uncommon that we can see larger fragments, mostly monolayer sheets of cells. And for the rheatic mesothelial cells, it is not uncommon that you can see prominent or distinct nucleoli. So you must be really careful to distinguish whether this is tumor cells or this is rheatic mesothelial cells. Because of these monolayer arrangement and the similarity between these cells versus the adjacent single cells, I think these are most likely to be the mesothelial cells and obtained from the washing force. But something is unusual is actually these not very distinct cells. However, similar to the prior experience, we do see eccentric nucleus as a signaling ring cell pattern, and with abundant cytoplasm with a little bit oranginophilic material inside it pushing the nucleus away. So this is likely a signaling ring cell carcinoma. So this is not the easiest specimen to screen. So in this specimen, additionally, we do see some mucinous, extracellular mucinous material, which is also uncommon in the ascites specimen. So here we have some more clusters of the Severin cell. So the patient does has a Severin cell carcinoma. They still don't know the primary. Maybe it's coming from the gastric, but we do see these Severin cell adenocarcinoma in our specimen. So this is unlike the prior specimen. When we see two-cell population, our attention will be attracted to these larger fragments, but this is actually likely to be reactive mesothelial cells instead of the true neoplasm. The true metastatic tumor cells are over here. Okay, so this is quite difficult to screen. So the next specimen is also a peritoneum washing specimen. The patient has endometrial cancer and received surgery. So in these washing cytology specimen, we have a very scant cluster of cells, but with high-grade nuclear atypia. And we can appreciate there are some mitosis over here. And this is three-dimensional, so you really need to focus up and down to see clear every cells. So this is positive for adenocarcinoma, high-grade and compatible with the patient's impression of endometrial high-grade adenocarcinoma. So the next specimen is also coming from a patient with gynecologic cancer. So the patient had a history of primary peritoneal serous carcinoma, which is a high-grade serous carcinoma. In this specimen, just on low power, you can see that they are small but tight aggregates of cells. So these are what we call the second population. So when we see that, we will usually go to higher power to confirm the morphology. So these does show features of high-grade adenocarcinoma. Just compare the size of the nucleus. So this is very big, and this is hyperchromatic, arranged in like a three-dimensional architectural pattern. So this is positive for adenocarcinoma, consistent with the high-grade serous carcinoma. So the next specimen, 72-year-old female with history of breast cancer. This is also, the patient also present in our emergency department. So she had the history of breast cancer for a long time and was suspected to have lung metastasis as well as pleural effusion. So the specimen is relatively difficult to screen. We only see a lot of inflammatory cells in the background. They are very, very rare atypical cells, and our screener is able to identify. I see this is probably the only cell is highly suspicious. You can see the size of the nucleus, but it is not very well preserved and overlap with these inflammatory cells. But you can appreciate that the nucleoli is also very prominent. So this is likely to be a metastatic cancer cell. So if we only have these single cells or only a few these highly atypical cells, and the patient doesn't have the prior proof that it's already in the pleural effusion, we will usually use the suspicious category instead of directly call these positive. The patient also have a cell block. So in this cell block, we can see a few cells with very similar morphology, such as this one, and these are in cluster. So you see big nucleus, prominent nucleoli, cherry red. So this is very similar to what we see in the cytospin preparation. So we have a few these type of cells in our pleural effusion specimen. So I think it would be nice that we can do a immuno to confirm that this is from the breast, so we can more confidently call these positive for metastasis. So for the breast cancer, we will usually use a marker called GATA3. However, GATA3 can occasionally has this cross reactivity with lymphocytes. So you see in the background we have a lot of positive nucleus, but these nucleus are all very small, which means that it is not what the tumor cell that we see. So we know from our HE, the tumor cells are very, very scant, and the nucleus is very big. So this is actually a positive tumor cell, but the rest are all cross reactivity with the lymphocyte. So we really need to identify the morphology of the tumor cell and to check the immunoreactivity on these positive cells. So in this specimen, the immunostain is a little bit difficult to interpret, and the key is to identify the true tumor cell and to confirm that it is positive. So it is positive, and we can call this metastatic breast cancer. So let's move to fine needle aspiration. So we have a patient with 2 aspiration of the breast lesion. So she is a 40-year-old female, relatively young. So this is her liquid-based preparation specimen. So on the first glance, we realize it is hypercellular, a lot of cells, a lot of cell cluster, and they all look very blue. So when we go to high power, we can identify in the background there are a lot of necrotic debris, which is not good. So this looks like carcinoma with tumor necrosis. So this specimen is enriched with these hyperchromatic cells and a lot of necrosis. So this is positive for carcinoma. In the breast aspiration cytology, sometimes it is quite difficult to distinguish whether this is an in situ lesion, particularly ductal carcinoma in situ, or it is an invasive lesion. And most of the time, we want to look for myoepithelial cells in the background, which usually presented as small oval cells with naked nucleus. I think for this specimen, it's very difficult to see which is myoepithelial cell. So I checked the concurrent biopsy specimen. The patient only have DCIS in the biopsy specimen. So despite these high-grade appearance and massive necrosis, this is likely all coming from the DCIS. In the cytology specimen, we call this positive for carcinoma, but we won't be able to comment whether the carcinoma is in situ or invasive. So this is positive for carcinoma, and the biopsy show DCIS, and the cytology show very prominent, like a high-grade tumor cells with massive necrosis. So the second case is coming from thyroid. So for the thyroid aspiration, this is the liquid-based preparation. We want to see if there is background colloid. So this specimen on low power, you can identify that we don't have colloid and we don't have a lot of cells as well. So this is a relatively paucicellular specimen. We do have a few clusters of cell aggregates. So we want to go to higher power to confirm the morphology. So when we go to higher power, the cell show enlargement as well as like an oval shape of the nucleus. But otherwise, the other nuclear feature of papillary thyroid carcinoma is not very apparent. So we have some overlapping, a little bit oval shape, and enlargement of the nucleus. That's it. So if this is the only specimen, only focus that we have, we will probably call these AUS, with cytologic atypia. But we want to see more. So again, clusters of cells in like a proteinaceous, clad in this proteinaceous material. Again, the features are very similar, just enlargement, slightly irregularity of the membrane, and that's it. But it's getting there. It looks suspicious for papillary thyroid carcinoma. So luckily, we also have the direct smear. So we will go to the direct smear to see if we have more diagnostic material. So we have a little bit more over here. Again, on low power, no colloid, but the relatively like a fragments of aggregates of cells. So this is getting better because we can identify some pseudo inclusion over here. So there is a small pseudo inclusion over here. And through the direction of smear, we identify these cells all looks enlarged, relatively atypical. And we can see pseudo inclusion over here. So if we have enough diagnostic material, we can just go ahead to call these papillary thyroid carcinoma. So we sign out this case TBS6 malignant, and we specify that it is a papillary thyroid carcinoma. So the next specimen is also very similar. This is from our branch hospital, from the thyroid, and with only direct smear. So these specimens, we do see more diagnostic cellular material. In the background, we don't see a lot of colloid. And here, we see a papillary fragment. So we have the architectural pattern of papilla. So these are all fibrovascular stroma. So you can appreciate that most of them were single, like a spindle cells, and with collagenous material in the background. However, the lining cells seems to be all like falling apart from these stroma. So we can go ahead to take a look of the background, like an epithelial cell. So these all looks like an oval with very irregular nuclear membrane. And here we do have a pseudo inclusion over here. So the low power pattern is highly suspicious for papillary thyroid carcinoma, and we just need to go to higher power to confirm the cytomorphology. So we do identify a lot of these pseudo inclusion. So this is also positive for papillary thyroid carcinoma. So another thyroid aspiration. So for this specimen, we also only have direct smear. This is coming from our endocrine department, they do have a lot of experience with the loose stain, the dry smear. So for this specimen, most of the materials are on this dry smear. So we only have these loose stain preparation. So in the background, again, no colloid, a lot of blood. So this is a bloody aspiration. And then we start to see like a larger cellular fragments. So the fragments does have some stromal tissue. So then we go to higher power. So the morphology, when we go to high power, the cells has abundant cytoplasm. And we do see like these fine granules in the cytoplasm. The nucleus is big, but it is centrally located. So the morphology is consistent with oncocyte. So this is consistent with the oncocytic rich aspiration. When we see this type of specimen, there were a couple considerations. If we do see colloid in the background, a lot of colloid, which suggests that this is actually a hyperplastic nodule and with oncocytic change. If we don't have a lot of colloid, but we do see a lot of lymphocytes in the background, then we need to consider the possibility of lymphocytic thyroiditis. So for this specimen in the background, we don't see colloid, we don't see lymphocytes, but we start to see these larger fragments of cells, and we can appreciate that aggregates of oncocytes with some stromal tissue. And particularly in some area, we do identify what we call transgressing vessel. So here is a small papilla, like passing through these aggregates of epithelial cells. So this is a strong evidence suggests that this is a vascular rich tumor with little colloid. So this is consistent with an oncocytic tumor. So with the TBS, we will use the category 4, suspicious for follicular neoplasm oncocytic subtype. So this is an oncocytic tumor, very classic. And we only have these loose stain for us to see. So finally, we have a pap smear from a 49-year-old female. So she's approaching 50, but still have a lot of superficial cells. And the background is quite clean. So usually for these type of specimen, what we look for is the precursor lesion because it is very clean. So we just need to screen for the precursor lesion. So for these specimen, along the smearing direction, we have area showing these vague coilocytic pattern. The nucleus is slightly enlarged but not particularly hyperchromatic. So slightly enlarged, vague coilocytic change, but no hyperchromasia. So this is consistent with ascus, atypical squamous cell. So we do see relatively abundance of these cells, but most of them were just like a very vague. It's not clear true coilocyte. Some just with perinuclear halo, and the nucleus are all very normal chromatia. So this is consistent with ascus smear. So if we have more hyperchromatia, we can go ahead to call this low CO. So pay attention to conventional smear, because when you sample from a focal lesion and you smear your like a brush, you will definitely more common to see the smearing direction. You will find this lesional atypical cell along this smearing direction, and then it is not common that you can see anywhere else from these specimens. So this is a typical pattern for a precursor lesion. However, for this case, the cytologic criteria is not complete, fulfill the criteria for low seal. So we call these ASCAs. And we realize that for the HPV infection, sometimes the patient can clear the infection, so these may be transient. So sometimes when you do the colposcope biopsy, you won't identify a lesion. So these may come and go. So we have stricter criteria for our precursor lesion. So this is for field diagnosis of ASCAs. So that's for all the case today.
Thank you.
Thank you.